This conference will now be recorded.
Sure. Thank you. Okay, I'll give you 2 more minutes. Please join fastly. I'll start the class in 2 minutes. Okay, I'm going to start it now. Start the class now. Am I audible to everybody? If there is anything you want to say, you can just ask me in between also. Any questions? Okay, today's my class is disorders of amniotic fluid. Amniotic fluid is the fluid which surrounds the fetus from early pregnancy. Okay, it is produced and cleared continuously. There is continuous production and continuous clearing of the amniotic fluid. It has been estimated that the entire volume of the amniotic fluid is replaced several times a day. So what are the major sources of production? The first major source of production is fetal urine. Once the fetal kidneys start functioning, the fetal urine is the major source of the amniotic fluid. What are all the major routes of clearance? Fetal swallowing. So whatever amniotic fluid is present, the baby will start swallowing it. That is the major routes of clearance. And what else? Intramembranous transfer of to the fetal blood. So through the skin and membranes, it is being transferred to the fetal blood. These are the major routes of clearance. What are the minor sources of production? Secretions from the fetal, oral, and nasal cavities. What are the minor routes of clearance? It is transmembrane transfer to the maternal blood. It is not the fetal blood. The maternal blood is minor route of clearance. Okay. So now, what are the compositions of amniotic fluid? What do you have? What is the liquid? What does the amniotic fluid? What does the liquid consist of? It contains carbohydrates, proteins, lipids, urea, creatinine, uric acid, lactate, and pyruvate. And it also has electrolytes, enzymes, hormones. Glycerophospholipids like lecithin, sphingomyelin, phosphatidylglycerol, phosphatidylinositol, and growth factors. Growth factors such as epidermal growth factor, transforming growth factor, insulin-like growth factor 1, erythropoietin, granulocyte, colony stimulating factor. And also it contains cells like amniocytes and stem cells. This is all the composition of amniotic fluid. It has all the cells, hormones, growth factors, electrolytes, and excretory products such as urea, creatinine, carbohydrates and proteins and lipids. These are all the products, what is the composition of amniotic fluid. So what is the volume of amniotic fluid? The volume of the amniotic fluid varies from the gestational age to gestational age. During early gestation, that is around first trimester, what you say 12 to 14 weeks, it is about 50 ml. When the gestational age of the fetus reaches 16 weeks, it will be 200 ml. When the gestational ages reaches 28 weeks, then you call it then the amount is 800 ml. So in the late trimester, third trimester, that is 34 weeks, 40 weeks. At 34 weeks, it is peak level, 1000 ml, that is around 1 liter. But after 34 weeks, it slowly starts declining. And by the time the fetus reaches its maturity, that is 40 weeks, it is 500 ml. This is volume. So basically, what are all the functions of amniotic fluid? Why does the fetus require amniotic fluid? So first major point is protection. Protection of the fetus from the trauma. It acts as a buffer zone. So whatever shocks and everything trauma, it protects the fetus from the trauma, the amniotic fluid, and prevents umbilical cord compression and supplies nutrients, and also it provides space for the growth and development of fetal skeleton, lungs, and gastrointestinal structures. And it provides growth factors. It has antibacterial properties, and it maintains temperature and forms a hydrostatic wedge in the labor. That is, it helps in cervical dilatation. The bag of membranes which forms during the latent stage and active phase of the labor will help in cervical dilatation due to formation of hydrostatic wedge. Okay, these are all the functions of amniotic fluid. So clinical applications. So clinically, what are all the advantage from amniotic fluid? What can we learn clinically by doing amniotic fluid analysis? In second trimester, we can collect fetal cells for karyotyping, and you can determine fetal gender, fetal sex, whether it is a X fetus, which is a female fetus, or a XY fetus, which is a male fetus, so that we can study X-linked disorders. And because of the karyotyping, we can study chromosomal defects, and we can diagnose intrauterine infections also. Okay, such as rubella, toxoplasma, cytomegalovirus, parvovirus, etc. So in third trimester, we can study what is the amount of bilirubin in the amniotic fluid, which helps in diagnosis and treatment procedure for RH alloimmunization. And you can detect lecithin, sphingomyelin, phosphatidylglycerol, which helps in determining fetal lung maturity. And you can when there is rupture of membranes, the amniotic fluid leaks into the vagina. So when you test the vaginal pH, we can detect, if it is alkaline, we can say that there is rupture of membranes. So these are all the clinical applications of amniotic fluid. So volume of amniotic fluid inflow and clearance per day at term. So at term, when the fetus has reached 37 weeks, we call it as a term fetus. So what happens? The production of the fetal urine is around 800 to 1200 ml. And what about the fetal lung secretion? It is around 170 ml. And what about oral and nasal secretions? It is about 25 ml. So this is all comes to production. Production. After production, we'll discuss about the clearance. So what is the clearance? Fetal swallowing, where fetus can swallow about half liter to 1 liter per day, and intramembranous transfer is 200 to 400 ml, and transmembranous transfer is about 10 ml. So this is the production. What is the amount of production and what is the amount of clearance per day? So evaluation of the amniotic fluid volume. So how do you evaluate? It is mainly by ultrasonographic examination of the maternal gravid uterus. So what are all the measurements you take for evaluation of amniotic fluid? One is single deepest pocket. The other one is amniotic fluid index. So let's come about the abnormalities. Let us discuss abnormalities. So first one is oligohydramnias. So in oligohydramnias, what is defined? What is exactly oligohydramnias? In oligohydramnias, it's nothing but reduced volume of the amniotic fluid, which can be defined as an AFI less than 5 centimeters, or when there is single deep pocket less than 2 centimeters. Okay, an AFI between 5 to 8 centimeters is considered borderline or low normal amniotic fluid volume. Oligohydramnias is usually suspected when the uterine size is less than what is appropriate for gestational age. Women with pre-labor rupture of membranes may present with a history of vaginal discharge, and then women who presents with complications, PIH, that is hypertension, preeclampsia, and post-maturity. Post-maturity is gestational age more than 40 weeks, and other maternal risk factors for maternal insufficiency. You have to perform an ultrasound for all these high-risk patients to look for AFI. AFI is amniotic fluid index. You have to rule out oligohydramnias in high-risk patients such as hypertension, preeclampsia, post-maturity, and other complications which can cause placental insufficiency. So what is the differential diagnosis? Differential diagnosis is wrong dates. When there is wrong dates also, you can say that the uterine size will be less than the gestational age. And IUGR is fetal growth restriction. Even though amniotic fluid is good amount, it is not reduced, but the fetal size is less. Then also the uterine size will be less than what is appropriate for the gestational age. In such cases, you have to suspect, you have to rule out oligohydramnias. So oligohydramnias, wrong dates, and IUGR. So these are the three conditions where you will have an uterine size less than the appropriate for gestational age. For those things, you have to do an ultrasound and you have to check your LMP-EDD. You have to correlate the dates of the patient with the first trimester ultrasounds to verify whether her dates are correct or not. So what are all the causes of oligohydramnias? There are maternal causes, fetal causes, drugs, and idiopathic. What are the maternal causes? Pre-labor, rupture of membranes, postpartum pregnancy, preeclampsia, pre-gestational diabetes, placental abruption, and dehydration. What are the fetal causes? Fetal growth restriction, twin-to-twin transfusion, genital anomalies such as renal agenesis, outflow obstruction to the urinary tract, polycystic kidneys, and chromosomal anomalies like triploidy, trisomy 18, Turner syndrome. And drugs, which drugs causes decrease in amniotic fluid? That is prostaglandin synthase inhibitors, AC inhibitors. And sometimes you may not find any of the cause, then you call it as idiopathic. So what are all the complications which can arise due to oligohydramnias? Maternal, if there is pre-labor rupture of the membranes, then she can develop chorioamnionitis. Chorioamnionitis is other than infection in the intrauterine infection during labor, and she may end up in induction of labor, instrumental delivery, and cesarean section. So how do you take the so if the patient presents, what is the history you have to take? Whether there is any watery or blood-stained vaginal discharge, whether the patient has any hypertension, preeclampsia, pregestational hypertension, APLA. APLA is antiphospholipid antibody syndrome. And you have to verify about the family history, any congenital anomalies, any chromosomal abnormalities, and you have to ask for medication history, any intake of AC inhibitors, prostaglandin synthase inhibitors. And then you have to go ahead and do a physical examination. In physical examination, again, measuring the blood pressure is the important thing. And then you have to check whether the uterine size is corresponding to the gestational age or not. And you have to see whether per abdomen on palpation, whether reduced amniotic fluid is present or not. So when the on per-abdominal examination, when you are doing your examination, if you are able to feel the fetal parts very easily, then you can say that the amniotic fluid is reduced. And then you have to do a speculum examination. In speculum examination, you can see watery, bloody stent discharge, and there will be pooling of fluid in the posterior. So what are all the investigations you do? You have to do an ultrasonogram to confirm the diagnosis and to estimate what is the AFI. So if oligohydramnios is confirmed, what you have to do? You have to do a targeted ultrasound to rule out congenital anomalies such as renal agencies, polycystic kidneys, outflow obstruction, and you have to see for any markers of chromosomal abnormalities and fetal growth restriction. And then you have to go ahead and do a placental localization and see whether there is any abruption. Okay, this is investigations via ultrasound. And then if there is a history of watery vaginal discharge, then you have to go ahead and do a speculum examination. And then you can take a vaginal swab and do microscopic examination where you can see whether there is firming, and you can what do you say, you can test the pH of the vaginal fluid. If it is more, the pH is more than 7.5 by the nitrazine test, you can confirm that it is rupture of membranes. Generally, vaginal pH tends to be towards acidic side. So if there is rupture of membranes and the amniotic fluid is leaking into the vagina, there is alteration in the pH of the vagina. The pH will shift from the acidic side to the alkaline side. So if it is alkaline side, pH will be more than 7.5, and it can be tested by the nitrazine test. If it is on the alkaline side, then you can confirm that there is leaking of the amniotic fluid. So how do you manage? Management always depends upon what is the gestational age at the diagnosis, and then what is the cause of the oligohydramnios, and what is the fetal prognosis. See, fetal prognosis is rather than how whether there are any congenital anomalies, whether the anomalies are fatal or not. It depends upon all these things. So in first trimester, if there is reduced gestational sac fluid, as such, we cannot do anything about it, because in first trimester the baby is not survivable. So what we can do is only serial ultrasounds. That's all. Other than that, we can't do anything else. We can just monitor. If it is during the second trimester, then you have to explain to the patient, to the parents, that the prognosis is poor if the oligohydramnios is detected in second trimester. And then we'll, after counseling, we'll go ahead and determine what is the cause of the oligohydramnios. And sometimes you can go ahead and do an amnio infusion under the guidance of ultrasound. And if there is any, after ultrasound, proper targeted ultrasonography is done, and if there is any fetal anomaly which is lethal is detected, you can suggest termination of the pregnancy. You can recommend termination of pregnancy. And then if no lethal anomalies are detected, then you can do a follow-up serial ultrasonography is recommended. So if the oligohydramnios is detected in the third trimester, then what do? It depends again on the gestational age. If it is a postpartum pregnancy, you can deliver the baby. If the fetus is growth restricted, if oligohydramnios is associated with a UGR, the management is directed towards underlying medical condition, and the fetus should be monitored again by the serial ultrasound combined with Doppler studies, and delivery should be dictated by the fetal condition. That is, if the fetal Doppler studies indicates that the delivery should be imminent, then you have to deliver the baby. Woman, so what happens if the woman is with preterm pre-labor rupture of the membranes? This can be monitored carefully till the patient reaches 34 weeks gestation. You can just monitor her, but the monitoring should be terminated if the patient will develop chorioamnitis and any signs of sepsis. Until then, you can monitor, and the cutoff point of monitoring is until 34 weeks. So once the patient reaches 34 weeks, you can give this coverage and then deliver the baby. And then women with idiopathic, where we don't know any cause, you have to monitor the pregnancy with non-stress test, serial ultrasonography, and biopsy profile. So again, timing of the delivery, it again depends upon what is the etiology and what is the condition which is associated, such as preeclampsia, IUGR, any anomalies. So generally, idiopathic oligohydramnios are delivered at 38 weeks. So how do you manage the labor? You should closely monitor the labor in case of oligohydramnios, and continuous electronic monitoring with CTG is recommended. And membrane should be ruptured because most of the oligohydramnios is associated with meconium staining or fetal heart acceleration. So that's why it should be closely monitored by the CTG. If there is meconium staining or if there is any fetal heart alterations in the CTG, you can go ahead with an amnio intuition. And if the fetal heart rate abnormalities persist, you can take up a cesarean section. So that is oligohydramnios. Until now, any doubts, ma? Any doubts? Okay, I'm going ahead with the second abnormality amniotic fluid, that is polyhydramnios. We have finished up oligohydramnios. We are going ahead with the polyhydramnios. So how is polyhydramnios defined, or how do you diagnose this? If polyhydramnios is diagnosed, if AFI is more than 25 centimeters or single deep pocket is more than 8 centimeters. Polyhydramnios is again classified into mild, moderate, and severe. Mild, mostly 80% of the cases are mild, where vertical pockets are 8 to 11 centimeters, or AFI is 25 to 30. Moderate, where vertical pockets is 12 to 15 centimeters, and AFI is 30 to 35. Severe, it is 5% of the cases where vertical pockets are more than 15 centimeters and AFI is of more than 35 centimeters. So what are the etiology? Fetal conditions like gastrointestinal obstruction, esophageal atresia, duodenal atresia, which inhibits fetal swallowing. Because there is no fetal swallowing, there is no clearance of the amniotic fluid, then they can lead to, what do you say, polyhydramnios. And neurological abnormalities like anencephaly, myotonic dystrophy, spina bifida. What happens in these neurological conditions? There is inhibition of swallowing and lack of ADH from the pituitary gland, inhibition of swallowing and translation from the exposed meninges. Next, fetal aneuploidy, that is trisomy 18 and 21. Again in here, it is inhibition of swallowing and intestinal abnormalities and non-immune hydrops. What happens in non-immune hydrops? Twin-to-twin transmission syndrome occurs. In RH immunization and parvovirus, there is increased urine output due to fetal anemia and cardiac failure. And in alpha thalassemia, there is fetal anemia and cardiac failure. In Bartter syndrome, there is polyuria due to renal hypokalemic alkalosis. And in maternal conditions, these are all, what are all the above conditions are? Fetal conditions. In maternal conditions, diabetes mellitus. This is polyuria due to fetal hyperglycemia. Because of the diabetes, there will be maternal hyperglycemia. Because of maternal hyperglycemia, there will be fetal hyperglycemia. And this fetal hyperglycemia in turn leads to polyuria. So what are the clinical features? So mild polyhydramnios can be detected by ultrasonography. Moderate and severe are associated with overdistension. In oligohydramnios, the uterine size is less than what is corresponding to the gestation age. In polyhydramnios, what happens? There will be over distension. So the uterine size will be more than the gestational age of the fetus. Okay, and this over distension will cause dyspnea because the big uterus will push the diaphragm upwards, and there will be pedal, vulval, and abdominal wall edema due to uterine pressure on the inferior vena cava. And polyhydramnios usually develops gradually, but sometimes there will be very acute and symptomatic also. So what are all the different diagnoses of polyhydramnios? When the uterine size is bigger than what is corresponding to the gestational age, you have to suspect multiple pregnancy, any ovarian cyst with pregnancy, any maternal ascites. Okay, and sometimes acute hydramnios should be differentiated from placental abruption, where there is concealed hemorrhage. The hemorrhage is the blood is getting accumulated in the uterus, so the uterine size grows. That's why you have to rule out placental abruption. So complications. So due to over distension of the uterus, sometimes there will be premature uterine contractions and preterm labor, and due to sudden release of fluid due to rupture of membranes can cause placental abruption. And in the presence of over distension, the uterine contractions are poor, leading to dysfunctional labor and postpartum hemorrhage. And malpresentations, malpositions are common. There is considerably increased risk of operative vaginal delivery and cesarean sections due to malpresentations, malpositions, and hypotonic uterine urine. Cord prolapse can occur because of malpresentations and malpositions, and fetal macrosomia can be associated with maternal diabetes, and perinatal mortality is increased 2 to 5-fold due to congenital chromosomal anomalies, abruption, prematurity, and operative delivery. So, what is the history? The patient is presenting you with a case of over-distended uterus. What history you have to take? Whether it is a gradual or sudden abdominal distension, whether she is presenting with any dyspnea, pedal vulval edema, and there is any tight feeling in the uterus, and physical examination. Inspection, over-distended uterus will be seen. On palpation, you will see that the uterine size is larger than the gestational age, and uterus is tense, fluid thrill, difficulty in palpation of fetal parts, and malpresentations. In auscultation, what do you see? Muffled fetal heart sounds. And in ultrasound, what do you see? Single deep pocket is more than 8 centimeters, or AFI is more than 25 centimeters is used to confirm the diagnosis. So, comprehensive ultrasonographic. So, a comprehensive ultrasonographic evaluation is performed for any fetal GI anomalies, any anencephaly, spina bifida, hydrops, and if it is a multifetal pregnancy, you have to roll a TTTS, and then you can do a amniocentesis or cardiocentesis for fetal karyotyping, and if hydrops is detected, whether you have to evaluate whether it is a immune cause or a non-immune cause, and if there is any parvovirus infection, and thalassemia also can be ruled out. And GTT should be ordered for the mother to rule out any gestational diabetes. So how do you manage? In most women with polyhydramnios, no cause is found. Therefore, management is directly at relieving of the symptoms and optimizing the timing of the delivery. If there is any etiological factor that can be identified, you have to address that issue. If you think that the patient is having diabetes, that is GDM, then you have to address that issue. If there is any fetal anomaly which is incompatible with the life, such as anencephaly, you can suggest termination of the pregnancy. And if there are any aneuploidies or other congenital anomalies, you have to consult a geneticist and a neonatal and pediatric surgeons, and you should take their opinion whether the baby is salvageable or not. So, idiopathic polyhydramnios is most common. So, how do you treat? It depends upon the severity of polyhydramnios, it depends upon the gestational age, and it depends whether the patient is having any symptoms or not. So, in women with severe polyhydramnios, the management depends upon the gestational age. decompression amniocentesis, that is amnio reduction to reduce the amniotic fluid volume to normal. You can give indomethacin for the maintenance of normal AFI, and you can give betamethasone 12 mg intramuscular every 12 hours, 2 doses to accelerate pulmonary maturity, and you can do serial monitoring of amniotic fluid volume by ultrasonography and deliver as close to term as possible. You can wait till the baby reaches term. So what are all the complications of amnio reduction? They can land in preterm labor, they can land in premature rupture of membranes, placental abruption can happen, and sometimes infections, which is very rare. So indomethacin. What exactly is indomethacin? Indomethacin is prostaglandin synthetase inhibitor. So what is the mechanism of action? It simulates fetal vasopressin production and reduces fetal urine production. So what is the dosage? 25 mg 4 times daily oral, and can increase up to 2 to 3 milligrams per kg per day. So what are the side effects? Mainly maternal side effects, nausea, gastritis, vomiting, and sometimes instead of polyhydramnios, they can land up in oligohydramnios. What are all the fetal complications? Closure of the ductus arteriosus, renal damage, renal failure, and it should not be taken. The indomethacin tablets medication should not be taken after 32 to 34 weeks of gestation. So what is the timing of delivery? Women with mild to moderate polyhydramnios can be delivered at term. So you can wait until 37 weeks. Until then, you can do a planned decompression. Pre-induction ripening with prostaglandins and labor induction with oxytocin can be used if needed and is not contraindicated. So how do you manage the labor? Fetal light and presentation must be confirmed before induction to make sure that it is vertex presentation. And sudden decompression due to spontaneous rupture of membranes can cause to placental abruption or cord prolapse. So therefore, you have to do a controlled amniotomy with a needle puncture, which is recommended. And always do a pelvic examination after the rupture of membranes so that you can identify if there is a cord prolapse immediately, and you can also identify whether there is any malpresentation, and then you have to give prophylactic uterotonics, which can be used to prevent any postpartum hemorrhage. Okay. So any doubts? I'm taking your attendance now. Let me know if you have any doubts.
Ma'am, AFI is measured at which gestational age, ma'am?
AFI generally will measure from second trimester.
Ma'am, then polyhydramnios can't be the gestational trophoblastic neoplasia. I mean, molar pregnancy can't be a differential diagnosis for
Yes,
polyhydramnios.
yes. Can be a differential diagnosis for polyhydramnias when you take it as the uterine size is greater than the size of the gestational age, right? But the thing
Only
is, polyhydramnias generally manifest in your third trimester, and your gestational trophoblastic disease will not be delayed as such. It can be a differential diagnosis in your second trimester, not in your third trimester. You got my point?
yes, ma'am.
See, if it is GT&D, it will be diagnosed earlier. It won't wait. We will not wait until the third trimester to diagnose your gestational trophoblastic disease. If there is a molar pregnancy, it is diagnosed before second trimester. Within 14 weeks, 16 weeks, or 20 weeks, you will diagnose your molar pregnancy. But when it comes to polyhydramnias, you will not diagnose until late second trimester, that is around 26 weeks, 28 weeks, and then most commonly polyhydramnias will present in your third trimester, that is after 32 weeks. So yes, it can be a differential diagnosis for polyhydramnias in your second trimester, but not in your third trimester. Okay.
Even if it is a partial mole, ma'am.
Yes, even if they partial more, until unless the patient is not presenting to you until she reaches her EDD, until she reaches her term gestation, generally we'll recommend scans, right? We will do a basic scan in first trimester, you will do an anomaly scan in second trimester, you will do a growth
Mm,
scan in third trimester. So you will detect your molar pregnancy earlier, right? Because of all these basic scans. Until unless the
yes,
patient doesn't present to you without any scan, then only it can become a differential diagnosis, which is a very rare thing, right?
yes, ma'am.
Okay.
Yes, ma'am. Thank you, ma'am.
Anything else? Okay, ma. Anything else?
No, ma'am.
Okay, thank you. You understood, right?
Yes, ma'am. Understood,
Oh,
ma'am.
yeah, yeah.
Ma'am,
Yes, ma'am. Please ask.
how will the fluid go through transmembrane into the maternal circulation, ma'am?
See, always there will be a little amount of translation between the membranes. How do you get your lymphatics? Lymph lymphatic fluid is again transmembranous translation, right? It can occur anywhere.
Yes, ma'am.
Okay, it will occur in the amniotic fluid also. That is the mechanism. A little bit of leak between the membranes will occur anywhere. Even the lung fluid is due to transmembrane translation.
Okay, ma'am. Ma'am,
Yes, yes, please ask.
ma'am, in polyhydramnios, if we do amniocentesis, then will there be any uterine decompression, sudden uterine decompressions like that? Means the
See,
port
we will
side is
not do.
very.
You can do uterine decompression, you can do amnio reduction, but we will do it slowly so that there is no sudden decompression which can lead to placental abruption. It is under our control, right? Under asymptomatic precaution, you will paint the abdomen, you will take a sterile needle, you insert the sterile needle, take a syringe, and you will pull out the amniotic fluid slowly so that there is no sudden decompression.
Okay, ma'am.
If it is a spontaneous rupture of membranes at term, then sudden decompression can occur. But when you are doing a procedure like amnio reduction, it is under your control, right? So you will do it slowly.
Yes, ma'am. And the site will be opened only. I mean, like, how will you
It,
close that site, ma'am?
there is no site, Amma. It's only a needle, right? It's like an injection puncture needle. There is no
Uh,
need to close.
okay.
It's a spinal needle which we are going to use. It will be a trans-abdominal procedure. No need to close it. It will get sealed on its own.
Okay, ma'am. Thank you, ma'am.
Okay. Anything else? Anybody else, ma? That's all. I'm leaving the meeting then. If there is any doubts, you can just post me in the group. I'll try to answer. Thank you.